this is good. We got all kinds of extra time here to talk neurosurgery, brain surgery, as they say. And I'm sitting here going, okay, I feel pretty comfortable. Did a little bit of research on the idea of it, but I will ask Dr. Weingarten, if you would, do me the favor of if you will, dumb it down for me here, because I am not a brain surgeon or a rocket scientist. That's got to feel pretty good though when somebody says, "What do you do?" I'm a brain surgeon.
It can actually be a little bit awkward at times. It's a bit of a conversation stopper sometimes.
We'll worry about making sure the conversation keeps moving here as we move forward. Kevin Kerrigan from the Guam Regional Medical City. And just a note, we're setting up an opportunity in the next couple of weeks to spend some time with the president-elect of the AMA. I think that's fascinating.
We are. We're looking forward to having him here. He's going to be a guest to the Guam Medical Society. So we're set for Tuesday morning.
I'm looking forward to having a conversation with him. Now getting into the conversation about, and again, neurosurgery, in my mind, I'm thinking it's brain surgery, but I didn't realize until I'd done a little bit of research that it really is much more than that. If you would, pull the microphone up to you. I want you to talk directly into the center of it, just like Kevin does, so that we can hear everything that you've got. I want to be able to hear the hairs in your nose whistle, if you know what I mean.
Gotcha.
So it's more than brain surgery. There's a whole big, vast area that you work on as a neurosurgeon.
Sure, absolutely. So, you're right. People think of it typically as brain surgery, and for many of us, that's why we got into it. I certainly got into it to be a brain surgeon and to work, with the human brain. But actually, a good majority of what we do is not brain surgery. With the typical neurosurgeon's division of cases, about 70 to 80% of what we do is actually spine surgery. So spine surgery is typically divided between either orthopedists who have done a special fellowship in spine surgery or neurosurgeons. So about, like I said, 70 to 80% spine, typically 20 to 30% brain, and then sort of a small amount of peripheral nerve surgery, which is shared typically between either orthopedics and plastic surgery.
That's it. We know a couple of guys from around here that have done some of that fine work that is required for the nerve specialties. But I am curious about what kind of surgery can you get away with on the spine? I always thought that was a no-go place.
So that's a great question, and interestingly, a lot of people who end up doing specialties in spine kind of get some teasing by the people who prefer to do brain, because it's thought to be more sort of the carpentry of neurosurgery, putting screws and rods in things and straightening things out. And
Home Depot.
Our screws are just a lot more expensive. But in fact, the spine is incredibly delicate, and in some cases can be more of a challenge to operate on than the brain. The majority of what we do in the spine ends up being either degenerative spine disease, which is to say, everyone gets older, everyone's spine starts to kind of break down little by little. We all have little herniated discs over time, and sometimes they start to press on nerve roots and cause pain. So a lot of what we do is just trying to decompress those nerve roots, which is to say, take the pressure off of them, take the discs away, replace them sometimes, and
what do you replace them with?
So there are a couple of different things you can do. Historically, it was done with other pieces of bone. Okay. So you can take a piece of bone from, one of the bones in the leg. You can take a piece of bone from the hip. More modern neurosurgery and spine surgery is typically done with artificial spacers. So they basically have a kind of polymer cage, basically a plastic of sorts, that gets filled with a bone-like material to provide seating for what they call fusion, which means essentially you're trying to make the bone above join with the bone below.
Now, when you do something like this, I'm trying to think if there's ways that we can marry technology that I might be more familiar with. I can see where you'd want to be able to create something. Can you do that with 3D printing? If they come out with the technology that would allow you to say, okay, these are the dimensions that I'd like to build this spacer out of, and send that to a medical 3D printer, and then half hour later you got something that you can put into somebody's spine?
So that's a great question, and in the brain side of things, we actually do that. There are times when we have to remove a piece of the skull, and if for whatever reason we're not able to put it back, maybe it was because of a trauma, maybe because it was of an infection, then we can actually do a CT scan make a 3D printed model of part of the skull and essentially put back a perfectly sized, perfectly shaped piece of the skull right into the defect. In the spine, though, that typically doesn't end up being necessary because our goal in a lot of cases is actually to make the body do the job for us.
I see.
So, we take out the disc, and we haven't, there are some disc replacements, but in many cases that's not clinically appropriate. So
I keep going back to your analogy of saying this is the construction area for surgery. Yeah, we've got some shelf parts that we can stick in there.
So in a sense, that is the way it works. We can cut pieces out, we can put pieces in, we can use a lot of hardware essentially to remodel the spine. But thankfully, like I said, the body does a lot of the work for us. And so once we put one of those spacers in, the goal is actually for bones to heal together.
Nice. Dr. David Weingarten is with me in the studio. He's a neurosurgeon with the Guam Regional Medical City. How do your patients come to you? I mean, I can think in my head, brain surgery, guy gets in an accident, a motorcycle, not wearing a helmet, and they say, Dave, we got a patient for you. But there are other ways that patients will come to you. What are some of those methods? People listening right now going, yeah, I do have this tick that maybe he can take care of.
Sure. Typically, they come to us through a primary care provider. So I would say the three main ways are sometimes a radiologist will have a finding that they'll go ahead and refer to us. Sometimes it's a primary care provider. So you go to your family doctor, you say you got back pain, it's shooting down your leg, and that kind of cues the family doctor or internist into ordering the appropriate scans. They find something, say they find a herniated disc or something like that, and then they refer to me. And then, of course, as you said, the most obvious one is the emergency room. So, people get in traumas and things like that, or come in unconscious, and you find that they've had bleeding into their brain or something of that sort, and they get referred to me.
No, we've got, I can think of, golly, 4 or 5 people in my life that don't sleep in a bed or have chronic back issues here, and they've been taking the pills and they've gone to the chiropractors and things like that. And as you say, it might be some kind of herniated disc issue, something like that. And so for people with chronic back pain, there are neurosurgical venues to relieve them of that pain and cure them.
So there are, although I should make sure and clarify, what we call axial back pain, which means it's just in the back. It's not radiating to the arms. It's not radiating to the legs. There's no electric shock sensations going down your extremities. The kind of pain that's just in your back is typically not resolved very well with surgery. Historically, a lot of surgeons would say, oh, great, you got back pain, your back looks like it's got some degeneration, we'll throw a whole bunch of hardware and we'll make a lot of money, and we won't really help you very much, is what ended up happening. So over time, what the research has shown is that if it's purely that sort of what we call axial back pain, that surgery doesn't help it very much. What we're good at helping is when there's a neural element involved, which is to say, again, that radiating, shooting pain, if you got burning pains going down your leg or down your arm, and it turns out that there is something like a disc pushing on a nerve root and causing that pain. Once we take the pressure off the nerve root, that pain
should disappear.
Will frequently go away. Yeah.
Now you're talking about pain, but are there all other symptoms, weakness in an arm or a leg or something like that will trigger some of the response to maybe go see a guy like you?
Absolutely, and that's one of the things that actually determines urgency in these sorts of issues. So just having pain, radiating someplace is not necessarily a reason to be going in and emergently operating on somebody, because some of these things will actually resolve with conservative therapy. So doing physical therapy, losing weight, sometimes what we call epidural steroid injections, which typically either an anesthesiologist or a radiologist will do. Those things can help to resolve that.
That's not
without
fun for you. You're a surgeon. Tell them, I want to cut something.
That's true, absolutely. But it is important for us to go through some of those conservative measures prior to just cutting on people.
Yeah.
As much as I like to do surgery, I like my patients to get better after surgery, and it's important for them to have tried conservative measures first.
How invasive can that kind of surgery be? Again, I'm thinking about guys that I know with maybe some of these shooting pains down their leg, and you're a cyclist, I'm a runner, and there's different kinds of places where we get the different kinds of impacts on our system based on the kind of athletics that we do. And I know some folks that have got some issues with their back, and maybe surgery is going to help. How invasive is that?
It very much depends on the extent of surgery you need.
Yeah.
Now, I had the privilege to train at UC San Diego with some experts in minimally invasive spine surgery. So I certainly have the tools at my disposal to be doing that kind of minimally invasive surgery, which is typically done, for example, with a little tube dilator. So I'm actually operating down through a tube and really minimally disrupting muscles and bones and things of that sort that would cause pain. That being said, not everyone's a candidate for that kind of surgery, and sometimes you need the bigger surgery, and that can be very invasive, and it can take months to recover from.
Wow.
But that's the reason to come and see me, to determine whether or not
which one you need.
You would be a candidate.
Now,
for something
they bought you, Margaret bought you all the things that you need to do both kinds of surgery, right?
So some of those things tend to come from the companies just on a by-need basis.
Oh.
So the tube dilators, for example, are not something that we're keeping in stock here, because it's not something that we use that often. But I keep in close contact with our reps for various spinal instrumentation companies, and they're poised and ready to send us things when we need them. So we do have all of the equipment necessary to do spine surgery, and particularly I made sure that we were ready for traumas and things of that sort.
In my mind, it seems to me that you are also very, very dependent on imagery, and the question that I've got here is between the different vendors, radiology guys around here, plus what you've got over at GRMC. Do you have access to all of the CT machines that you need, all of the MRI, that kind of imaging that you need to be able to go in and do it? I mean, do we have enough slices on this toaster here to give you a pretty good view of your patient?
Sure, that's a great question. From a technical perspective, we have some phenomenal equipment. There are a number of different providers on the island who have been providing excellent radiologic services, but also at GRMC we have state-of-the-art MRI and CT scans, all of the X-ray equipment that we need. Probably the biggest challenge that the island in general faces in terms of getting the resources that we need is staff. It's not the equipment resources. The equipment resources, by and large, are here. It's recruiting people to run that equipment. And we have techs for MRI, we have techs for CT, we have techs for ultrasound and X-ray. But to provide 24-hour-a-day, 7-day-a-week coverage with those folks is quite a challenge at times.
And depending on what you're coming in with, I mean, if you're coming in from an accident where you might have been jostled around, where your bell might have gotten rung, it's very, very important that you have, in the very least, in my mind, a CT scan, right?
Sure, and we certainly have people on call that we can call in at any time of day or night. It's when you sort of move into the gray zone of, well, this doesn't really need to be done right this second. It could wait till the morning. That staffing is a little bit of an issue.
Well, if it hurts and you're dizzy, demand a CT scan depending on what you've got. That's the high-tech side. What's the high-touch side? I mean, as a surgeon, as a doctor, at some point you've got to put your hands on the patient and kind of feel around. I mean, is that a big component in your diagnosis of a patient?
Well, yeah, absolutely. I mean, my interview with a patient, that is, getting the history and doing a physical exam is critical. And if you ask 5 different spine surgeons about a particular image, you'll get 5 different answers as to what needs to be done. And a critical element of that is actually examining the patient and finding out what their symptoms are. There are surgeons who are extremely aggressive and would operate on anything that doesn't look 100% normal on a scan. If a patient doesn't have symptoms, I don't feel like that's an appropriate thing to do, because I treat a person, not an image.
But it's the symptoms that can be kind of tricky for the patient before they realize that they need somebody with your skills. Among the symptoms that I read about were just changes in your bladder and bowels, and most people are pretty regular. Most people know about what it feels like when it's time for them to eliminate. And if you've got some changes to that, that may be a sign that you might need to see at some point down the road a neurosurgeon. Why is that? What's the connection?
So that's a great question, and it goes back a little bit to some of what you were asking as well about there being other symptoms than pain. Mm-hmm. So as you mentioned before, weakness, particularly if it's weakness just in one limb or just in part of one limb, like if you can't lift up your foot anymore on one side, or if it's starting to get weak, if you're starting to trip over stairs, that sort of thing, it indicates that you've got something that may need to be treated sooner rather than later, as opposed to just the pain, which may resolve over time. And with regard to the bowel and bladder issues that you're talking about, those particularly if they come on all of a sudden, say you twist, you're holding a big weight, you feel a pop in your back, and all of a sudden if you're finding that you're really having a difficult time going to the bathroom, then that's a reason to really urgently, emergently come into the ER and be seen and get that scan, because the longer you wait after you get that sort of nerve compression, the less successful surgery is going to be. So the nerves that control your
you just described something that happens to people all the time. I mean, there's there's opening a drawer where you're putting on your socks. You might feel that familiar twinge in the back, and you don't realize that might actually lead to something that may require surgery. That's fascinating, and also fascinating that I can't sit up straight while I'm talking to you. This is kind of leaning into the conversation. Dr. David Weingarten from Guam Regional Medical City, again, neurosurgeon, and it's a lot more than just what happens in your head, and we'll find all the way down to the spine. One last thing for me, I've got a caller on the line that wants to chime in on this, is when you operate on somebody, I assume, especially if it's something along the spine, that you would go in from the back. Are there ever any times where you'd crack somebody down the front to get access to what you need to work on?
There are. More often we're coming in from the side. Now there are some neck surgeries that we do where we do come in through the front, just basically right to the side of your windpipe there. But if you're looking at the lower back, around the sort of chest or abdomen area, typically we'll actually come in from the side, so that we're avoiding the bowel and things of that sort. There are cases in which we have to go sort of straight down the middle, but most of the time it'd be more likely from the side.
Craziest thing that you found inside somebody's head?
Oh, gosh. Well, we've got a bit of a knife and gun club back in San Diego, so, I've certainly taken bullets and knife fragments and that sort of thing.
What's the prognosis on things like that?
Depends where it ends
up.
Where?
Yeah.
And how extensive.
Run into people that might not remember what they had for breakfast this morning, but can all of a sudden play the piano. You just never know what happens with the brain. And there's still a whole lot that we don't know about what goes on in there, huh?
That's one of the reasons I got into it. It's fascinating.
Yeah, I suppose so. There's 477-5757, star 57. Last thing. How can I try to be as proactive and preemptive as possible? What can I do today to maintain a certain amount of a healthy brain, of a healthy spine?
Two very different questions there. With regards to the spine, one of the most important things, honestly, is exercising and maintaining a healthy weight. We end up with a lot of patients who have horrible back pains. You look at their scans; they have terrible degenerative spine disease, and if all they do is lose weight, then some of that back pain will go away, and you can avoid an invasive surgery just by staying healthy and losing weight. With regards to the brain, probably number 1 and 2, and I
well, what vitamins do you take?
It would be hard to place these on number 1 and number 2. They'd be sort of tied. Alcohol is not good for the brain, and excessive alcohol use on a chronic basis will literally shrink your brain. And number 2 would be helmet use, and that's something that I hope to really get involved with here on Guam, and with some public service, really trying to get people to use their helmets. They do save lives. They save brains.
No, it's bicyclists, need to wear helmets. Guys on the mopeds need to wear helmets. Guys on the motorcycles need to wear helmets. I'm not the kind of guy that tells you what you have to do. I don't want it legislated. I think that everybody is free to make their own choices. That being said, when I get on a cycle, even though I know I look like a weenie, I wear my helmet. Just for me and for the family. 8:57. Carl, real quick for you. Good morning.
Oh my God, thank you. Ray, take vitamin B. The doc will agree with me.
Vitamin B?
Vitamin B is in boy.
Right. Okay.
For the nerves. Doc, I'm a traumatic brain injury survivor, and I have brachial plexus injury. It happened in 2011, and I really don't remember whether or not I was wearing a helmet. But you know what? I have a paralyzed right arm and a paralyzed right lung. And I went to the Mayo Clinic, went to the Good Samaritan, went to Cedars-Sinai, and each one of them told me the same thing. Don't hold your breath. One of those things. And now that you're here, maybe I can breathe again. Because, technology is moving forward, helping people with spinal cord injuries. And I want to see what's available at your end here. Hello?
How can he see you?
Well, he can certainly give our clinic a call. The main hospital number is 645-5500.
I'm a guy with one hand. I'm holding the phone right now.
Tell you what, I'm going to put you on hold, Carl, and Bob can get you that telephone number so that we can put you on a speaker or something like that, and you'll be able to get the deal, and hopefully you've got the right kind of insurance to get in there. Yep. Press the red button there, Kev.
We'll get his contact information.
Okay.
We'll reach out to him.
Very good. We'll find you. Very close, very dear personal friend of mine, a familiar voice on K-57. John Anderson joins me. Good morning, John.
Good morning, Ray. How are you?
I'm doing very, very well. Thank you for asking. What do you got for Dave?
I just wanted to know if the doctor is familiar with deep brain stimulation.
I am. I've done several deep brain stimulator cases when I was at UCSD.
And also with the Medtronic DBS patient programmer?
I am. We don't have one of those. DBS is something that I don't plan on offering here, partially because it requires a really specialized team for movement disorders. But I have certainly used those devices.
Well, I've undergone the surgery, and I have the programmer. I haven't found anybody here that knows anything about it.
Well, we can.
I underwent surgery in May in Hawaii.
Okay. Well, I think probably the thing to do in a circumstance like that would be for me to make contact with your physician. So if you were to come and see me for a consultation, then I could get some of your medical information, and then what I'd really need to do is speak with your physician that implanted the device and who programmed it. And typically those are two different people. Most commonly, the person implanting it is not the person programming it. We work very closely with neurologists. I work very closely with Dr. Justin Hale, our inpatient neurologist at GRMC. And like I said, we do not have here a specialized movement disorders program, but I'd certainly be happy to speak with you and with your doctor to see if we can help you with the maintenance of that device.
That sounds good. I'll do that.
All right, John, and we know how to reach out to you, and we'll see if we can get something going.
Yeah, and do you get the phone number?
We have your phone number, right? We know how to find you.
Okay.
John, I'll see you pretty soon. Thanks for calling.
Okay,
Ray. That in and of itself a whole other conversation that we can have about some of these degenerative diseases that are floating around that more and more of our senior citizens are succumbing to. So we'll see if arrangements can be made for another chat with you.
Sounds good.
Looking forward to it. Dr. Dave Weingarten from the Guam Regional Medical City, and we've got Carl's number. We'll hand that over to Kevin in a second.
Killed a dozen